Good afternoon, everybody. This is Mariana Nork at Anchor. We're going to wait about another minute to let people have the chance to join. So please hang tight for about 60 seconds, and we look forward to bringing you right back. Let's run with it. Again, good afternoon, everyone. Mariana Nork, Anchor's Chief Corporate Engagement Officer. In my capacity at Anchor, I have the absolute pleasure of engaging with many vendors who work in our space and with all of you. But I particularly appreciate engaging with our Anchor national partners like IntellectAbility, who demonstrate unwavering support for Anchor, our mission, and all of you, our members. And today, on behalf of Anchor, I'm really excited to kick off the webinar called Would You Rather Report an Incident or Prevent One? Using health data to reduce harm and improve outcomes, which is presented by IntellectAbility. But before we get into it, let me just share a few words about IntellectAbility, an organization that educates and empowers support teams, administrators, and clinicians with necessary and proven tools, risk attention, replacing risk with health and wellness. Summarily, IntellectAbility supports those who supports others. They created the first and most comprehensive suite of risk resolution and learning tools for professional supporters, tools that empower, educate, and inform those responsible for protecting, maintaining, and restoring health, wholeness, and a good quality of life for people with IDD. I know our presenters will tell you more, but let me just take a minute to thank IntellectAbility for their tremendous support of Anchor. They have been a deeply valued Anchor national partner at the gold level for several years. Additionally, Craig Escudé is also co-chair of the National Partners Program, and I deeply appreciate Craig's leadership and participation. So let's get right into today's important discussion. I'm delighted to introduce our panelists, Craig Escudé, who is president of IntellectAbility, and Daleigh Tallent, who is clinical director at IntellectAbility. Craig and Daleigh, I know you're going to say a lot more about yourselves and the company, but thank you so much for joining today and for this fabulous presentation.
Thank you, Mariana. We appreciate you being here today, and I've always appreciated the partnership with Anchor. And for those of you that are listening to this webinar and who are not Anchor members, I would highly encourage you to visit their website, learn more about Anchor and the benefits that you can receive as a provider of supports and services for people with intellectual and developmental disabilities. A couple of housekeeping notes before we get started. If you have questions, we would love to entertain them as best as we can. I'll be monitoring those through the presentation, and hopefully we should have time at the end to answer some of your questions. You also have handouts in your handouts section of your control panel, so if you can find those, and you can download the slides as well as a couple of other resources, a couple of other brochures. You will also see a link, you should see a link or have seen a link in your welcome message when you joined that has a link to a survey. We take those surveys very seriously, so we would very much encourage you to complete the survey at the end of the webinar. Tell us what you liked, what you didn't like, what we can do better, what you'd like to hear more about in the future, and if you'd like someone to reach out to learn more. So please take a look at all of those things. Before we get started on what I consider a pretty important topic about how do we prevent these incidences from being something that we prevent them so we don't have to report them, I'm going to tell you a little bit about more about myself, and I'll let my co-presenter Daleigh introduce herself. I'm a family physician by training. I started in this field in the late 90s and learned how little I actually knew about providing good health care for people with IDD when I began in this field, and learned a lot over the next several years. I've had a little over 20 years of clinical experience as a medical director for an intermediate care facility in Mississippi. And again, very eye-opening and learned a lot. And as we begin to move more people out into community settings, I realized that healthcare was something that really needed to be addressed, because we know that most healthcare providers are not properly trained in medical school or nursing school or other health professional schools to provide good care for people with IDD. So I developed a program we called Detect in Mississippi to provide training and education and consultations to clinicians out in community settings who were seeing more people with IDD and complex medical and mental health conditions. That led me to learn about our company, IntellectAbility. We are a company that provides tools and training to supporters of people with intellectual and developmental disabilities to help them identify those health risks early, again, before they become reportable events or before they become hospitalizations or before they result in preventable death in people that we support. And it dovetailed so much into what I was doing in Mississippi in trying to provide training and improve health outcomes. So I joined the team as president in 2018. I've authored The Clinical Pearls in IDD Healthcare, which is a book resource that's used to provide information about various topics related to health and wellness, as well as a curriculum in IDD healthcare, which is an online course to train clinicians. And I also host the IDD Health Matters podcast. If you're a podcast listener, we have 159 episodes out so far. So you can certainly find information from guests, from doctors and nurses, as well as administrators in the field, from direct support professionals, from self-advocates, from leaders of agencies. So another resource that you might find of interest. So I'm going to ask Daleigh to introduce herself.
Thank you, Dr. Escudé, and hello, everyone. My name is Daleigh Tallent, and I'm a registered nurse. I've been a nurse for a little over 13 years now, and over the past 8 years or so, I've supported aging and IDD populations. I began nursing in acute care and then found my way into long-term care, and then really just fell into the field of IDD. And I'm just so thankful that I had a colleague that introduced me and I found my people. And that was in Georgia, where I was a provider nurse for many years, served in some leadership positions there, but also did nursing oversight for residential and community agencies. I joined IntellectAbility in 2021 as a clinical service representative, and I became the clinical director last year. So it's a pleasure to be here with you all.
Thanks, Daleigh. Our company, IntellectAbility, has 3 sub-brands: the health risk screening tool, the HRST. I know some of you here utilize the HRST and some of you don't. The HRST is a tool that helps to identify health risks. It's a screening tool to identify health risks that are so often missed in people with IDD that result in many of these preventable conditions. And it provides actionable steps for supporters to take. You'll learn a little bit more about that later on. Our Academy sub-brand is all about training. It's filled with training courses, e-learning courses to teach supporters about so many health risks and how to recognize them early and prevent them. Underneath Academy, we have our productions line, which we produce all of our courses in-house using both internal and external subject matter experts to produce really high quality courses that can be utilized to train supporters of all levels. And we also have our 3rd sub-brand of person-centered services, where we teach states and organizations and help facilitate them to provide support in the most person-centered ways. Now, our objectives today are how do we move from reactive reporting to prevention, reactive things to preventing them. and using health information and observations and staff knowledge and trends to do that. How do we do that? What's the best way to do that? And to take this data that we're all collecting, we all know how much data we have. We're always collecting data and writing reports and filling out forms. But how do we take that data and turn it into something that is really usable, that can reduce harm and improve overall health outcomes? So I mentioned, and this was my traditional cycle early on. We would do what we always did in support of people, and then something would happen. Somebody would choke, somebody would end up in the hospital, somebody would have a fall with a big injury, or whatever it might be. So something goes wrong, and then there's an incident report that was completed. And sometimes, if it was high enough, it had to be sent to the to the Attorney General's office, and it would result in an investigation or whatever it was. If it wasn't that high, we would do what we needed to do internally. We would review the event. We would figure out, okay, what do we need to do different? Is there something that we need to do different? And there might be a corrective action plan that would occur. And then that would be put into place, but then we're looking at the next incident and the next incident and the next one. And this cycle of kind of reacting to challenges that happen, to bad outcomes, to health conditions, to injuries. And that was the main cycle that we saw. But what we want to talk about is, how do we move from that cycle to preventing these outcomes, where we notice a change, we see something early, because staff know what the early signs of all of these health destabilizations might look like, or there's a tool in place that can help identify these things. And we gather the necessary information related to what we're seeing, and we identify that as a pattern of risk to help us act early, to say, wait a second, we're starting to see some signs that this person might be aspirating, for instance. We've got to catch it early, or early signs of dehydration, or whatever it might be. And then we can look at those actions that we come up with and see if they worked. And if they did, great, we adjust the support plan, either to focus on those actions more, or to get rid of the actions that don't work. And then ensure that both the supporter and the person themselves are educated with what to watch for, what to look for, and turn these things from something that becomes a reportable event into something that we were able to prevent because we recognize things earlier. Most of these critical incidents have a history. For instance, somebody might have started on a new medication, or they might be ill from something, or overall developing some weakness, or having early dehydration, which might result in a fall. But those early signs and symptoms were likely there before they fell. Choking, you might see a person coughing or clearing their throat when they're eating. They're not swallowing quite as well, or maybe it takes them longer to eat. That one of those reasons could be because they're having trouble swallowing, or they may eat very, very fast, or they're not as awake. Those are early signs that a person is going to be at risk for choking and or aspiration. So many times we talk about behavior changes, and unfortunately, so many times we've said, well, that's just what people with IBD do, or that's just what this person does. They hit their head on the wall every once in a while, or they bite their arm, or they get really agitated and frustrated at certain times of the day. That's just what they do. But many times those behavior change is an early sign that could indicate a painful condition, something like or constipation, or reflux, where they're refluxing acid, or an early sign of infection, or medication side effects. So if we look at the early signs, we can recognize them and act to prevent those things. Many emergency visits, emergency room visits, emergency or hospitalizations, they often follow days or weeks of subtle changes, subtle decline. And if everyone is educated on what that looks like, they have methods in place to identify these things, we're going to be able to prevent those. Always look for the early signs. They're almost always there. When we go back and do mortality reviews, which we actually do mortality reviews, we might look back and see, wow, they had signs of X, Y, and Z about 4 weeks before they ever ended up in the hospital, or the health risk screening tool identified these 4 or 5 things, and that, it indicates maybe this could have been caught a little bit earlier. So look for the signs, know what to look for. They're almost always there. Another thing that's really important is to know the person's baseline. What is the person's baseline level of functioning, level of activity? How do they normally communicate? How do they eat? How do they, ambulate? Or what assistance do they need? When we know these things, it helps us to be able to determine that there's a change. For instance, maybe a person always, needed a wheelchair for long distances, but they could get around in, short distances fine. But in the last week or two, they've needed the wheelchair more. They're asking for their wheelchair because they aren't able to walk as far as they used to. That's an early sign of something changing. And so we've got to know a person's baseline, to know if it's typical for the person to be able to identify changes, to know when something began, to know if a change is persistent or worsening, and is there something else that might have changed at the same time? And one great way to do that is to use a document called the health passport. You might also hear it called a health resume, but it provides baseline information on that person's level of interaction and abilities and communication styles and all of these different things that can help supporters know if something is different or is different than the baseline. And this can be particularly helpful when you have maybe limited staff and you're being pulled from one place to another. They can look at that document and say, okay, this is the person's baseline. I know, if this is a change or not. So these documents can be used internally, but also externally when a person goes to a clinician's office or an ER visit to help those supporters and the nurses and the doctors know what that person's baseline is. This is an example of one that we have. It's freely downloadable on our website. We've got it in a couple of languages, and you can find other ones out there. I would just recommend using a version of a health passport. The other thing is to know the person's specific risks. Not everybody has the same risks or has the same challenges. So that's something to think about as well. What are their specific risks for aspiration? Is it swallowing related? Is it reflux related? Is it position related? Is it eating too fast? So what is that person's specific risk for some of these conditions, like aspiration and bowel obstruction? Do they not drink enough water? Do they not eat enough fluids? Are they on medications that cause an increased risk for bowel obstruction or dehydration, or seizures, or sepsis, or reflux, or falls, or behaviors that can cause self-injury? What are each person's specific risks? Because they're not the same for everyone. So we have a polling question here, and Daley's going to help me organize this or run this. But this is the question. She'll open up the poll in a second. How does your organization identify people at increased health risk? Do you utilize nursing or clinical assessments? Do you look at hospitalizations or incident reports? Is there some sort of standardized tool that you use? Or do you not really have a formal process? Is it just something that kind of occurs organically when people think, I think something's going on here? If none of these apply, feel free to type in a question in the chat. And we can add that in too. So we'll give it a minute or two for everybody to answer.
You got some good results coming in. So about 10, 15 more seconds, and I'll close the poll and share the results with everyone. All right, got a few more responses coming in. Last call, about 5 more seconds. All right, great. Thank you for the participation. Let me close this and share the results.
All right, 34% use a nursing or other clinical assessment. 15% look at incident or hospitalization trends. 30% use a standardized health risk tool, and 21% don't have a formal process. Very, very interesting insights there. All right, let's go on here. And not only do we need to know the person-specific risks, we need to know the person's specific preventive measures. What are the things that we need to put into place for each person? Like I mentioned before, aspiration can have multiple different risks. So what are some of the things that we might put into place to help prevent aspiration? And we've got to know that person's risk. Maybe it's diet modification. Maybe that person has difficulty with certain textures of diet. Maybe the person just needs to be monitored, maybe for pacing of the way that they eat, to help them, eat at a safer pace. If it's constipation, maybe we need bowel tracking, and I would say that would be very important. It could be a dietary consultation that we might need. It could be more fiber or fluid or whatever that the person might need. It could even be a pharmacy constipation for some of the medications that could be causing constipation. Falls. What about falls? Maybe do they need some sort of walking assistance or assistive device? Or again, pharmacy consultation could be utilized here because it could be medication effects or side effects, or looking at the overall environment of the person or their trip hazards that we haven't noticed. So we've got to not only identify the person's specific risks, but we've got to identify the person's specific preventive measures, because the same thing doesn't work for everyone. So another question here, and if you want to type in the chat, that would be great, and we'll try to look at those. How does your organization know what preventive actions and training are needed to be implemented? Nursing, develop care plans? Are these the types of, or where we get that information from? Is it from the team experience and discussion? Is it a physician or a specialist recommendation? Do you not have a formal process? Or is it kind of all of the above? And if you want to type something in the chat, that would be great to provide a little insight and information. We don't have a formal poll for this one, but still would like to know your thoughts, and you can add those in later if you feel so inclined. So as we go on, I'm not seeing anything in the chat, so we'll continue here.
There are, sorry, Dr. Escudé, there are some responses coming in under the questions.
Oh, under questions, great.
Yeah.
Let's take a look at those. Thanks for calling into my attention. All right, based on, I'm going to go back to the question. So based on experience, mostly, I see all of the above for a few responses. We have health tracking forms at the staff that are due at each shift, and then a nurse who helps manage their health risks. Overall team experience. And someone said we're not able to ask chat to access the chat, so that's a good reason there was nothing coming in there. Thanks for adding it to the questions. Sorry for the technical difficulty. Yeah, it's a mix, mostly responses to incidences, nursing and physician recommended. We don't have a formal process. So again, we see a mix of different things. Thank you all for sharing that information. It is important when we're looking at the people that we support to know their acuity level. And what do we mean by acuity level? It's a measure of a person's health needs and medical complexity that help determine the level of healthcare oversight, monitoring, and support that people require. Do people need a little bit of support, a medium level support, a whole lot of support? We might think we can see those things very easily, but I can tell you from personal experience, you might think someone is healthy, and they might actually have the highest risk when you use an objective measure of risk. They might have the highest level of acuity. And when we know that person's acuity level, it can help guide care planning. It can help us allocate resources and staff time. Who needs more attention? Who needs more nursing oversight? Who needs intensive case management services? And it can identify those people who are at greatest risk for that health destabilization that we were talking about, and that can help promote proactive and preventive care. When we have some mechanism to identify early risk changes, it allows us to go from that reactive way of thinking to the preventive way of thinking. Without some sort of acuity stratification, we're going to have delayed recognition of health changes versus early recognition and being able to do something to prevent those things. Without that stratification, care will be focused more from a crisis response type care rather than focusing on prevention and stability. You'll have frequent ER visits and hospitalizations without the acuity stratification, and with it, fewer preventable emergencies. And we have to talk about costs, especially now as we know that Medicaid budgets are shrinking in many cases. You have higher unpredictable and preventable costs without some measure to know which people are going to be most likely to have a major health incident or a fall or a head injury or an emergency department visit or a hospitalization or preventable death. And you have better outcomes with lower cost when you have a way to do these things. So we want to move from reaction to prevention. And now Daleigh is going to tell us about a couple of ways to do that. Daleigh?
Thank you, Dr. Escudé. So the first thing I'm going to talk about is the health risk screening tool, commonly known as the HRST. The HRST is a validated web-based HIPAA-compliant instrument designed to identify early signs of health risks for people with IDD and other at-risk populations, including people with physical disabilities or traumatic brain injuries, those that are aging, and as well as children. The HRST comprises 22 objective rating items that track changes in health risk over time. Because as Dr. Escudé mentioned, we're looking for patterns, we're looking for trends, we're looking for opportunities to intervene early. And when routine screenings are completed, you can really see those developing patterns of risk that can signal the likelihood of a significant health event. The HRST, it was developed in 1992 by Karen Green McGowan, a registered nurse and the founder of our company. It is currently used to screen over 130,000 lives each year across the U.S. And this map shows states and provider organizations that are using the HRST, as well as other IntellectAbility products and services. The states in dark blue use the HRST to screen for health risks across their Medicaid waiver populations. And several of these states use the tool in both residential and non-residential settings. And coming from the state of Georgia, I really appreciated that we were screening people in our residential settings as well as those in the day program, because risk doesn't change depending on the setting. A person is still a fall risk, whether they're at home or at the day program. They're still diabetic, whether they're at work or they're at home. So we want to make sure that those risks are identified across the support team. The states in the lighter shade of blue represent those who have individual provider agencies that are using the HRST, and the states striped in blue are using other IntellectAbility services, some of which we'll talk about a bit later. So how does the HRST work? Again, it is a 22 rating item scale, and it is designed to identify the people who are at the highest risk of illness and health instability. So each rating item is scored by answering a series of objective yes or no questions. And those questions will guide the user to a score from 0 to 4. The higher the score, the higher the risk in that rating area. And then based on the numerical total of the 22 rating item scores and a proprietary algorithm, a healthcare level is assigned. And healthcare levels, they can range from 1 to 6. Again, the higher the healthcare level, the higher the person's overall risk. And I want to just emphasize that the HRST healthcare level has been studied, and it has been demonstrated year after year to be a reliable predictor of mortality and a direct measure of clinical acuity in people with IDD. What I appreciate and most importantly is that the screening doesn't stop with just a number. It generates person-centered recommendations. We call these service and training considerations. And these are designed to help the team determine what actions, what monitoring, what planning or education should happen next. And as a nurse, I very much appreciate this. And I noticed that a lot of you responded that you're using your clinicians, your nurses, to help identify those risks. Well, as a nurse, I can tell you I wasn't trained to take care of people with IDD. So the things that I now know about this population, I didn't know whenever I entered the field. So the HRST really helped me as a provider nurse to bridge the gap between real world IDD care and what I learned in nursing school. And the result of the HRST is that, every person screened receives a defensible, evidence-based acuity level and a person-centered action plan to match. Next slide, perfect. So this slide shows each of the 22 rating items that make up the HRST, and they are divided into 5 different categories. The first is functional status, and this category surfaces risks related to choking, how the person eats, how they move about, how they transfer and walk, and other ADLs like toileting. The behavior category looks at specific behaviors like self-injury or aggression that can kind of clue us in to underlying medical issues. And this category also looks at the use of as needed or scheduled psychotropic medications. The physiological category looks at specific body systems, including some of the fatal 5 conditions that are sprinkled in there. Safety category includes injuries and falls. We know that a lot of incident reports stem from injuries and falls, so they're well represented in the HRST. And frequency of services. This category measures how often the person is utilizing community healthcare services for acute or chronic medical issues. And when taken together, these areas provide a comprehensive picture of a person's overall health risk and not just isolated diagnoses that a clinician may hone in on. Next slide, please. Thank you. So this is the HRST rating scale. Again, each rating item is scored on a scale from 0 to 4. A score of 0 means there have been no issues in this area within the past 12 months. As the score increases, we start to see increasing frequency of the identified risk. It's happening more often. We're starting to see identifiable patterns in the risk. It may be getting worse in severity, or we may be having potentially life-altering health events in that specific rating area. And what I like to emphasize is that we're not simply counting incidents. We're looking for patterns. And this really aligns perfectly with what we talked about earlier, that it's so important to recognize trends before they become emergencies. Not only does it help with cost utilization, but we're talking about saving lives and increasing quality of life and better outcomes. This is an example of what an individual screening might look like. So each rating item receives a score. Those scores are totaled into a score for each category. In this example, most rating item scores are low, but a few really stand out with higher scores. And that's what we want. We created a tool that allows you to immediately direct the team's attention to where preventive efforts should be focused. Because ultimately, we can't treat every health issue equally. And I think that's what that was stressful to me as a nurse, is how to prioritize the person's health. We are taught some strategies like that in nursing school, but there are some things we can actually prevent. And if we can do that, it's really much more efficient and person-centered. So the HRST healthcare level, again, I mentioned it's validated as a mortality risk indicator. The healthcare level ranges from 1 to 6, moving from lower risk to higher medical complexity and acuity. The healthcare level, it reflects the level of monitoring or clinical oversight that may be appropriate for each individual person, which is why some states use the healthcare level for rate setting or perhaps to determine services such as nursing oversight or that intensive support coordination. I think we can all relate to this slide. We just have so much data that's available to us. And one challenge is that sometimes there's often too much data. I don't think anyone's ever died because their medical chart was too large, but people can die if we don't use the data that we're already collecting in meaningful ways. And so the HRST, it takes all of this data and it organizes it into specific categories instead of leaving the teams, the DSPs, the nurses, the support coordinators. We don't have to then sort through all of these data points. The HRST aligns it all for us. And that's really what transforms the data into something that's usable. The data is also aligned into the considerations. So this is the output. This is my favorite part because it helped me as a nurse come up with new ideas because people are changing. People don't present differently. And as Dr. Escudé mentioned, just because someone has aspiration, their risk could look completely different from someone else. So the considerations, these are structured discussion points that highlight areas that may warrant further evaluation. Maybe we need to get a clinician involved. Maybe we need to adjust some supports and services for the person. And then we also want to have this conversation to allow the support team to provide their experience and some judgment based on their interaction and history with the person being supported. And the HRST really does have something for everyone on the entire support team. So nurses, physicians, DSPs, case managers, supervisors, therapists, everyone can work from the same understanding of the person's risks. And that clarity helps everyone be on the same page. And we're all looking at prevention in the same way. And consistency like that can really save lives. The service considerations, so valuable. These describe which clinical evaluations or professional interventions may be needed to reduce or even eliminate an identified risk. And that's really powerful, is understanding that we don't have to manage a risk. We can actually eliminate it altogether. And for each service consideration, we're going to get a corresponding training consideration. And training considerations highlight the areas that families and supporters should be trained on to better support the person's health and wellness. And this is where identified risk is really translated into coordinated, proactive support. Because it's great that we've identified a person's risks, but we want supporters to know where they need to start acting. And that means our training can become much more targeted instead of generic. And speaking of training, we know the risk. We can identify the risk with the HRST. We can implement and identify, training opportunities, service consideration opportunities. But let's go a step further. Let's train supporters in the identified risk areas, and this can be customized based on the population that you support. So that's why IntellectAbility developed the Academy. And our Academy provides credential training to all levels of supporters, from families to DSPs and even physicians who may need to learn more about how to care for people with IDD. And our Academy library has an extensive suite of e-learn courses, including training on the Fatal Five, which I'll go into a little more detail here in a moment, but how to manage choking. This is a short but effective e-learn course that talks about recognizing and preventing choking. And Dr. Escudé mentioned mortality reviews that we do, and we do see people choking for multiple reasons. And choking, we know, leads to aspiration pneumonia. And if our person goes into the hospital, their risk of dying significantly increases. So we've got to start with training. Another great one is actions speak louder than words. We know people with IDD or communication challenges will express themselves through behavior. And if we look at that behavior as a way of communication versus something that they've always done, we can identify a risk, we can address that risk, and that behavior could potentially go away altogether and change the person's life for the better. Dr. Escudé mentioned in his intro that he created the curriculum in IDD healthcare for physicians like himself and nurses like me that didn't get a lot, if any, training in their healthcare professional programs. So it's a wonderful way to create a foundation of knowledge on how to care for people with IDD. We offer person-centered thinking training, and I love this training because yes, we want to focus on the person's health risks. Yes, that's how we're going to keep them alive, but we have to consider what's important to the person. What do they value? What are their goals? And if we can combine those things and change our culture to a more person-centered culture, to a more preventive culture, we can really start saving lives and making a difference for those we support. Lastly, we have our productions. This is our in-house team that can create custom e-learn trainings for your organization. And here are a few examples of courses that they've completed for clients. And then lastly, just want to reinforce how important it is to train on the Fatal Five. We are still talking about the Fatal Five for a reason. Data has shown that people are still dying from preventable health risks like aspiration, bowel obstruction, dehydration, sepsis, seizures. So we have 3 tracks for Fatal Five training. We have our fundamentals designed for direct support professionals. We have our advanced Fatal Five training for clinicians that's also approved for CEs. And then we have our Fatal Five training for case managers, which builds on our fundamentals course and shows case managers how they can really advocate for health and safety when they're doing their visits. And now back to you, Dr. Escudé, to talk about some outcomes using the HRST in our training.
Thank you, Daleigh. And before we do that, I just want to remind everyone you can download the slides in the handouts section of your control panel. And if you have questions, type them into the questions box and we'll have time to get to them shortly. I do want to highlight that what we're talking about here is supported by data. Data means a lot. When we research things and we see the outcomes that we're talking about, it makes it a little easier to rely on something and to utilize something. And I want to talk about a couple of recent studies on outcomes. Daleigh did mention that the HRST has been studied to show that it is a predictor of mortality risk. And that's been published in the Journal of Nursing Measurement in 2020. And we have yearly reviews of that, which continue to show the same outcomes. But I want to talk to you about a couple of other ones that are more recent. There was an organization who in 2024 enacted screening for all 51 people that they supported with the HRST. And the following year, they had significant reductions in these areas. Behavior-related unusual incidences, so adverse behaviors, declined by 56%. One of the reasons for that is when people are not suffering from something that can be treated from, or they're having pain or discomfort from something that can be identified and fixed, they're not going to have as many adverse behaviors as a result of pain. The unanticipated hospitalizations declined also by 50%, and emergency department utilization declined by 53%. And that is in the year following the year that everyone was screened. That's pretty significant. That's pretty drastic. And again, when you're looking at Medicaid budgets, that reduces overall healthcare costs quite significantly as well. The total estimated direct medical cost avoidance was $136,000 for those 51 people. And that resulted in a return on investment of about 6.38 to 1, which is pretty significant. If you'd like to look at that study, you can scan the QR code there or reach out to us, and we can help you find it as well by visiting our website. Another example related to training. So Discovery Living implemented training for 230 staff members by requiring the Fatal 5 training. And that's all they did was require all staff to take the Fatal 5 training. They supported about 150 people with IDD and still do. They saw in the year following the training, a 37% reduction in emergency department and urgent care visits, estimated to be about $274,000. And then that's just in medical costs. When you add in staff overtime and then just the difficulty, we've got to call in staff because this person has to go to the emergency department, or we've got to bring everybody with them, or whatever it might be, significant savings there as well. Not only that, but it improved staff confidence. Some of the nurses were talking about how it's like, yeah, we hear people talking about making sure they have water now, whereas they were always having to encourage them, and now the staff are saying, wait, we need to grab water for everybody, or whatever it might be. And those are great types of conversations, the types of conversations you want to hear from direct staff. They're noticing that people were coughing when eating, and so they were able to catch these things earlier and intervene. And so it's incredible, again, what happens when training actually translates into action. This is not training that we were like, oh my gosh, I've got to sit through this training again. These are things that really make a difference in people's lives, and it empowers staff to do their job better, which helps with staff satisfaction. We know that there are studies out there, the better trained staff are, the better they like their job, and are more likely to keep it. So prevention works. It improves outcomes. It reduces overall staff burden. It reduces those reportable events. It turns people from thinking about things in a reactive way to a proactive way. And on top of all these other good things, it improves people's lives. It prevents people from suffering from treatable conditions because it's recognized earlier and it's treated. That improves overall outcomes for that person individually and collectively. If you are someone who's already using the HRST, and you need some assistance, you need some information, you want to learn how to utilize the service and training considerations more effectively, or whatever it might be. On the bottom of this login window, you see the green arrow and it says contact support. That's all you have to do. If you want to learn more about the HRST, how you can utilize it in your program or in your state, you can reach out to us. Visit replacingrisk.com, and you will be able to email us. You can email us directly. My email address is popping up on the next page, and we'll get you in touch, or get someone in touch with you to discuss these things more. So now we're going to open it up to questions. I think we have a couple here. So here, someone says, can we get more ways of preventing risks again with disabilities? I think we can get you lots and lots and lots of ways on how to prevent risks or improve outcomes for people with disabilities. I'll tell you about a few resources. If you visit our website, again, replacingrisk.com, you'll see a webinars page where we have regular webinars that are free for anyone to join, where we address different health topics or support related topics, and many of them are related to health risks. So that's a great way to learn more about it. And then you'll find some other resources on our resources page. Even the IDD Health Matters podcast has information about reducing risks on some of the episodes as well. So that's one thing, or a few things that you can do to get more information. Here's another question. How do you address the trend in doctors not prescribing anything stronger than Tylenol for pain management? Well, let me just say that, most things start with education, and we have to educate clinicians on lots of different topics related to this field. And yes, some people think that, oh, well, people with IDD don't feel pain in the same way, or they don't need more. And that's just simply not the case. And so it's educating people, educating clinicians that this person in front of them with intellectual disabilities is a person first and has likes, dislikes, and pain receptors like every other human being out there, and they should, be treated for pain in whatever way they would treat anyone else. And so it's really advocating for the people that you support, to ensure that they get the treatment in any area, including pain management. And unfortunately, we still, we have to do that. It would be nice if we didn't, if clinicians really understood, some of these concepts that we've been talking about. But again, coming from my own inexperience, I know that there are still many, 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 many clinicians out there that need to learn more about this field, which is, again, why I created that particular program and why we do what we do to help everyone, including clinicians, know how to support people better and reduce health risks.
I wanted to piggyback on that just a bit. Within the service considerations in the HRST, we also offer clinical briefs. And these are based on the person's scores in their rating items. But these were written by Dr. Escudé, and they're written from a doctor to a doctor perspective, or a clinician to a clinician. And it's topics and areas that, again, we didn't get trained on in our nursing schools or medical schools. But it's a way to educate. You can they're like little one-pagers. You can print them off and take them whenever you're going to provider visits. And it's a great way to advocate for appropriate supports and when people have identified risks.
Daleigh, while you're on, I'm going to ask you the next question. How often should a provider use the screening tool for a supported individual?
So the screening should be updated annually, at least once a year. Oftentimes that annual update time is maybe based on the person's birthday or their annual plan date, but at least once a year. And then with any changes in their healthcare status. So if someone goes to the ER and they're admitted to the hospital, the screening should be updated to reflect what happened during that hospitalization, why the person went. And then When that's done, new service and training considerations are produced. So maybe the person's health risks change, where you're going to want to go in and look at those considerations and see how your support actions need to change as well.
All right. Here's a quick question and then a longer question. Can you give us the site address to get a copy of the consumer cover sheet? I think you're meaning the health passport that we discussed. Just go to replacingrisk.com. And Daleigh, can you type that maybe in the questions just so they have it? But go to that website and you'll see a resources link. And there are lots of other resources there that you might find of help as well. But just look for the health passport and you can download it there. Someone asked, Dr. Escudé, as an HRST champion working with a multi-state agency that uses the HRST in some states but not others, what is your best advice for making the case internally to expand the HRST to the other states? That's a great question. And first, thank you for using the HRST and being an advocate of it. But I think, the more data that we present people with, the more of a case we make to utilize something like this. Those two studies, well, the one was on the HRST that I mentioned that showed the reductions in emergency room visits and reductions in hospitalizations. You can find that on our website, and providing that information to the decision makers in the other states, I think would make a strong case for utilization or expanding the utilization. It might be helpful, and I'd love to work with you on this actually, to look at your organization, but you guys can do this internally. Look at the overall incident reports and hospitalizations in the states that are using the HRST in your organization, and compare it with the states that are not. I mean, there are lots of variable factors that come into play: age, the people that you're supporting, the overall health levels. But if you could do that in a way that compares kind of relatively equal health status of people, it would be very interesting to see if the HRST in your organization results in overall outcomes, which would make the case to use it. So I really think it's looking at data more than anything. So I think this brings us, well, we've got a couple of minutes left. Let's see if we've got any other questions. All right, someone mentioned that they would love to use the tool, not so much mostly for decreasing hospitalizations and ED visits. Reach out to us. And again, the survey, if you click this survey, please, complete the survey, and there's an opportunity there to reach out to us, or just visit our website, replacingrisk.com, and we will have someone get in touch with you to do a demo for your team so that you can really get into the tool and see how it works. And I'll just tell you, I'll leave you with this. I learned about this tool, as a medical director of an intermediate care facility, and it actually, it surprised me that this was out there, and I didn't really know about it. And it was, I believe in the tool strong enough to have retired from my clinical practice when I really saw what it could do, and just the tremendous value of the tool. I'm like, you know what? I want to work to help more people know about this field, know about this particular tool, know about the training. And, I had second thoughts. It's like, well, I'm leaving my clinical practice. I'm leaving the people I've been providing healthcare for, but I worked to find someone who could provide healthcare as well. And now I know that what I do still affects people's lives in very positive ways. So while I'm not providing direct patient care, I know that I'm still improving health outcomes for people with IDD. And if, hopefully that drives home how valuable I really think this is. So thank you all very much for joining us today. Somebody said they went to the web address and you got can't reach that page. Maybe there was a typo. I don't know, but it's replacingrisk.com. But anyway, thank you so much for joining me today. Thank you, ANCOR, for supporting us and giving us the opportunity to do this.
Craig and Daleigh, thank you so much. This is great.
Everyone, you will get a recording of this webinar if you missed it or want to share it with anyone. So you will get that about an hour after the webinar. Thanks for joining us.
Bye-bye.
Bye.